본격적으로 우리 리필 컨퍼런스를 시작하겠습니다. 의자는 30세 여왕이고요.
ECG 컨퍼런스는 히스토리는 아니에요.
예.
ECG부터 보면서
타키카디아 EKG.
황태영 선생님 시작하시면
30대 여자이고 AI 시스템처럼 검단지를 쫓아내고 있습니다. 일단 네로가를 부탁하면 레이스 텍트 이거 되고 일단 빠르다 보니까 섹션도 또 시스템이 프로그램 키가 잘 보는지는 저는 잘 모르겠어요. 파레스
학원생 앞쪽을 찾는 게 쉬워요. 이곳에서 남들이 찾아가고
저는 레귤러랑 네로미터스 기자라고 있었지. 아이솔레이트 라인이 일본에서 나왔는데 스페셜리드 풀 했는데 하고 있는 거 이스라엘 이스라엘리드 이스라엘 플로터로 그리고 프랑스 트랜지션이 좀 포지티브에서 네거티브로 유지되는 상황이에요. 스토카디아 같은 느낌이 아닌가.
무슨 소리가? 뭐가 있다고요? 엑스트로카디아. 엑스트로카디아. 이건 느낌은 보인다. 릴스에 보면. 그리고 아까 말한 QRS는 구현이 R이 도미넌트하고 1AB를 D5, B가 도미넌트. RB 하이퍼트로피랑 RB 스트레이트. ST 디프레션도 풀코디알리티에 TAB 버전도 있고 있는 거죠. RB의 트레인도 걸리고 트레인 심장 엑시스도 롤스 웨스트면 완전히 기가 결론을 내야 되는데 롤스 웨스트면 위티를 페이버한 노맨스 랜드 아니에요? 뭐 특이한 심장은 엑시스가 많이 틀어져 있는 심장은 정상 심장은 아닌 것 같아요. 그죠? 엄지현 선생님이 이상하다. 주치의나 맞을 때 일도 못 맞춰. 네로퍼레스 카디하고 저게 뭐 간별 진단 당연히 리스트업 해야 되는 게 에이트럴 카디아 플러터 그다음에 PS 위치스 AB OBBMT ABRT 뭐 가능성 낮지만 사이너스 카디아 다 간별 진단을 해야 된다. 아마 이상준 선생님은 요 V1에 마우스를 좀 따라오세요. 이거 보고서 막 플러터를 의심했던 것 같은데 이건 뭐 하나의 간별 진단을 일단 난 그거보다 더 신기한 게 V1이 지금 R웨이브 T가 없는 건데 V5, 6가 네거티브 웨이브 있잖아요. 그거는 이상준 쌤이 보신 대로 뭔가 심장이 좌우가 바뀌어 있을 가능성이 꼭 생각해 될 것 같고 그다음에 김대웅 교수가 ABS 네거티브, 이번 네거티브니까 로스 웨스트 액세스라고 했을 때 만약에 일반적인 로스와 스타일을 보면 VT를 페이버하는 경우는 있는데 검정 선생님이 이것다를 했던 방울적으로. 근데 만약에 심장이 가오가 이렇게 있거나 비틀어져 있으면은 그건 뭐 수프라벤트를 뭐 나는 정확하게 모르겠지만은 추정하기는 언제 선생님 환자 같은데 언제 선생님 결론을 주시죠.
이게 물질과 잘 연결되게 되면은 와, 그 프레셔가 토너를 할 때 올라가 있는 매우 어린 소화가 아닌가요?
인포메이션 원래 안 주고 시작해야 되는데 저 사람이 첫 번째 순간에 잠깐 노출시켰어 비디오를.
문전 선생님 팔로우업 맞고 30세 지금
여자 30세.
선천성 있어요.
일단 컴플렉스 나한테
Okay. You guys, what's the differential diagnosis now?
안녕하세요.
안녕하십니까? 잘 들리세요?
네, 잘 들립니다.
Okay. So to be a BT, QRS is a really fairly narrow, right?
네,
Very narrow. And the axis, as you guys talking, could be right order axis precordially, so you could be right ventricular overload, pressure and volume is possible. Now, what's the atrial rhythm? What we atrium doing here? Did you make a decision? SVT versus atrial flutter versus atrial tachycardia, or VT1D one-to-one conduction?
에이트럴 플러터라는 의견이 나왔었습니다.
Atrial flutter. Okay. So then, how do you know it was atrial flutter? Can you explain that to me? Where's the flutter wave?
그다음에 설명해 보세요.
Well, we have to discuss this based on evidence of what you see. Is nothing to do with the history. History could be wrong too. So, tell me where's the flutter wave? I did not get that.
이상준 쌤의 플러터를 퍼스트 초이스로 얘기하니까 설명해 보십시오.
이제 그의 원인이랑 이제 수 붙는데서 아이솔렉트 라인이 다 보이는 걸로 생각이 돼서 플러터가 아닐까 싶어요.
So this is a flutter 1-to-1 or 2-to-1 conduction. What are you talking?
만약 플러터라면 원통 같은데, 그죠?
What's the rate of tachycardia? You see here? What's the ventricular rate?
한 200회 정도 되는 것 같습니다.
얼마?
200회 정도 되는 것 같습니다.
200. Okay. So you have a different type of flutter, right? We call type 1, type 2. What does that mean? Do you have any idea what we're talking? So we have a terminology in atrial flutter, type 1, type 2, typical, atypical. And we say right atrial flutter, left atrial flutter. We use a variety of different languages to communicate EKG. So what is a type 1, type 2 based on? When you read the literature, what are you talking? So we need to know those things, right? Otherwise, we'll be talking different languages here. So first question is, this is a classical type of flutter that you're guessing? Or this is some sort of a unusual P-wave flutter morphology of a flutter we are talking?
또 티피컬 플러터는 밑에를 밑에서 소스트 패턴을 보이고 일본에서는 팁을 보이기 때문에 티피컬 플러터는 아니라고 생각이 듭니다.
Typical flutter 아니다. So it's a typical flutter, morphology-wise, right?
네.
Okay. So when we say type 1 flutter and type 2 flutter, type 1 flutter is basically depending on the rate, okay? If your atrial rate ranging less than 330 to 350, we call type 1. Type 2 flutter would be a faster rate. So they're basically type 1, type 2 based on a flutter rate per se. And we know that when the heart atrial flutter rate get faster, because they are unstable, most likely degenerate into the atrial fibrillation. So that's been description in literature. That's number one. Now, atypical flutter we refer, depending if you're talking about right atrial flutter, we're talking clockwise or counterclockwise. Counter is a classical flutter and clockwise would be atypical flutter, vice versa. or sometimes they refer to the left atrial flutter. So we have to make some sort of a, agreement among the speakers. We probably should call typical flutter is what we call a counterclockwise right atrial isthmus dependent flutter. A typical flutter, they usually clockwise flutter. And then they separate out on the right and left atrial flutter. And type 1, type 2, depending on rate. That's what we understand these days. Anybody has any question or comment about this?
지금 선생님이 잘 설명을 서머리를 잘 해주셨는데요.
Yeah.
근데 그거는 일반적으로 로스리 스트럭처를 노마할 때 적용할 수 있는 크라이테리아고 이 환자들은 프리코디아 리드를 보는 넥스트로카디아나 뭔가 좀 아노말리가 있어 보여서
Right.
어떻게 적용을 하는지
No, still the same. Does not make a difference. As far as I know. Even congenital heart disease, we speak the same way. That's I know. They all depend on atrial morphology. Now, obviously, you cannot tell whether this is a right left atrial flutter because your atrial anatomy probably could be reversed, right? That's what you're referring to. So let me. Yeah, question.
하고 하기에는 지금 플러터 120이라고 그러면 200개 정도면은 일반적인 플러터에 비해서 조금 비교적 웨이트가 느린 편이 아닌가 그런 생각이 드는데요.
Then you have to speak could be a SBT. That fall in the category of SBT, right? Especially children, your SBT can go all the way to 280. Now, I'm asking you that's what I'm asking you. Well, how do you know this is a flutter or versus a SBT? That's what I'm asking. I'm hoping to use see that EGM here. So somebody said SBT or somebody said atrial flutter. So tell me why. That would be important here. If you look at the lead 1, okay, the terminal S kind of comes up and there is appears to be S segment depression, lead 1, and very end of QRS complex. If you look carefully, there's some variation bit to bit. Come to the next one. Okay, next one. What do you see? That initial depression get a little bit deeper, slightly. And then if let's say that's a 1 atrial activity, and come to the maybe B1, take a look at the B1. And especially when you enlarge your ECG, you can see better probably. So you guys can enlarge that view here on your screen. Can you focus into that bigger? Keep coming. There you go. Now you can see probably better. Okay. So if you look at that carefully, they're slightly deformed, it looks like. And other leads also, I see that. And how about the B4? You see show me the B4. Move to the B4. You see that first bit? Do you see that first S segment elevation end of it to the next bit? I think that's a first bit that the rate is slightly different. Can you see? There are 2 bit here, right? First bit is slightly longer than other. Look at the right at the before your P wave. What do you have? Some deformity there. Before first bit, go to that segment, come up a little bit to the left. There we go. You see that notching there? So this patient had a slight rate variation. We did some deformity changing back and forward. And you can look at the other leads as well. And that favor for not for the SPD, because that notching is real. This is 5B also you have it. Can you see it? Same bit? Yes. Keep coming down. P6. There is 2. Have you seen that? Now, look at your V3. V3. Yeah, there you go. Right after the QRS complex. No, come down. Yes, there's some notching there. And the next one. The next one, keep going. You can see that notching change a little bit. Keep coming. Some to become a little bit more notched than other. And then now you go to the next bit. Next precordial. Next, that's a lead AVF, I think. Next one. Go to the right side. Yes, that one. AVF. You can see clearly there's a second P wave or flutter wave, whatever you call it, right at the end of a T wave. ABF, yes, keep going. There is. This is a P on the top of a, your summation going on here. Otherwise, T wave would not be notched like that. So now let's ask this question. What is this favor to? Flutter or atrial tachycardia?
Both.
Both? Now you're telling me it's a both? Okay. Then go to lead 3. Let's see, I can convince you better. Lead 3. Yes. Take a look. Can you imagine could it be possibly 2 wavefront? First bit, right end of the QRS complex before the T wave? No, first bit, lead 2. Go there, and then before the T wave, P wave. Go, right there. Can you imagine there's a 2 complex going on? And you can measure the caliber, which of those intervals are same. Then this would be favor for flutter, not atrial tachycardia, or SVT. That's, I think, I would be favor for flutter, 2-to-1 conduction. I could be wrong, but that's the only evidence I see here. Any other comment?
V1을 봐서는 투톤 컨덕션이라고 얘기하기 좀 어렵지 않습니까?
B1?
네.
Why not? Your flutter wave axis is on. If you look at the B1 second complex, take a look, second complex. That's second. No, that's a third. First one is that one right at the end of the S segment. First S segment. Next one right there. You just passed. There's a small deformity there. So I think there's a slightly time phasic variation between QRS complex and this activity. Certainly could happen in SBT, but then very unusual, unlikely going to happen in the ectopic, more like ectopic tachycardia flutter pattern would be much more explainable, feasible than SBT. And then also your initial complex of T wave PR segment, supposedly flat. Is this patient changing PR segment? If you look carefully.
말씀하신 걸 서머라이즈 해보면은 일단은 아까 V 링킹이 깨진 게 잠깐 보였었기 때문에 SVT 가능성은 좀 떨어지고 atrial flutter나 ectopic atrial tachycardia를 생각해야 되는데 ectopic atrial tachycardia는 일단 ST 세그먼트에 보이는 좀 스몰 노출 가지고 ectopic atrial tachycardia를 더 페이버한다고 말씀하신 것 같고요.
PR segment?
펠로우드를 대변해서 한 가지 질문 드리면은요.
Yeah.
EKG가 보이면 물론 이제 지금 SVT는 어느 정도 익스클루전이 됐고 플러터 원투원이냐 AT의 투톤 컨덕션이냐가 이제 이슈인데 어차피 엄재현 선생님이 주치면은 EP 할 건데 그걸 굳이 이렇게 감별을 해야 될까요?
감별해야 되지. Why is the difference? Ectopic atrial tachycardia has a different mechanism, right? Focal tachycardia. Atrial flutter is a reentry. Is it not going to be important for you during the study?
뭐 웹에서 다 나오지 않습니까?
Well, but you have basically conceptually, you have a differential diagnosis based on the ECG much as you can. When you go focus mind, you probably make a better EP study than you think. Let's say that you put your catheter in. Let's say that this is a micro-reentry flutter from anterior wall. You guys are going to put a dodeca catheter, his bundle, so on. You entry from the right atrium, left atrium. You're not going to be able to entrain this, even the reentry. Am I right? So then you're still stuck, whether it's atrial tachycardia focal or micro-reentry. If it's a micro-reentry, probably you can differentiate quickly. But if it's not the case, then you're going to be in trouble. So that's why I think we still try to do our best. Look at the EKG, start thinking. Purpose of ECG is basically start thinking possibility based on what you see. But look at the EKG, and then you make much as an opening differential diagnosis. This apply not just for this ECG, any case that you see. So I still think that we should think all these things. Okay.
할 말이 있는 것 같습니다.
Okay. Yes. Question, please.
디시전 메이킹 하는 데는 큰 차이가 없을 것 같긴 한데.
라고 EP하는데?
네, EP를 결국에는
Well, that's what I said. You don't know whether this is a micro-reentry, or focal atrial tachycardia. Dr. Park question. If that's a scenario, you may put your CS catheter a little bit differently, maybe, instead of a duodeca catheter. Then I think a question become, where is this flutter coming? So if you do, let's say that you do duodeca catheter, you cannot entrain, then you have two choice. One is that you have to do somehow anterior pacing of left atrium or roof somewhere. You see it quite often in the people. You end up doing transeptal, and then you're mapping that area. So I think if you think that a micro-reentry, you need to map much closer, much more precisely than focal tachycardia to ablate this. But anyway, this is a congenital case. Is probably your catheter placement may be different. I don't know how do you guys put the catheter in this patient, but that's what I see in the EKG. I think I favor for flutter 2-to-1. Okay.
인비스비 EP를 하면은 어느 정도가 밝혀지겠지만 아웃페이션 클리닉에서는 저런 감별 진단이 되게 중요해요. 어떤 약제를 쓸 건지, 환자를 또 어떻게 설명할 건지, EP를 하면 석세스 레이트가 어느 정도 설명하려면 그런 거를 감별하는 게 사이너스 EKG를 한번 가볼까요, 이제?
What do you think? Is still dextrocardia?
바뀐 것 같은데? 어떻게 된 거야, 이거? 엑스카디가 아니었는데? 그냥 알고 있죠? 근데 여기서도 지금 근데 이상준한테는 말린 것 같은데. 자, 황태현부터 읽어봅시다. 같은 환자냐고 물어보지.
10회 정도 사이너스 레이드인데 사이드로 되고 엑시스는 노멀 그 예측했던 거랑 그건 밑으로 비스트리에 웨이브가 보면 스피드 버전이 있어요. 말들이 하이퍼트로피나 페이지 불리는 이상한 거.
자, 최 선생. 알겠어?
So I think Dr. Prabhujavin, did you read his question? He's asking whether it's a VT or could it be a fascicular VT?
이거 채팅 써볼까요? 이거 채팅 못 씁니다.
You see there his question. I think he's sending a question. So what's this totally the sinus rhythm EKG shows?
이상준 선생님 결자해야지 않습니까?
아까 QRS 트랜지션 보고 엑스트로카디아나 스트럭처럴 디지가 있는 환자라고 생각했는데 지금 순전도로 보니까 노말 에시스의 QRS 트랜지션도 정상이라 아까 봤던 순전도가 RBBB 그러니까 포스테리어 파시큘라 블락이 있는 환자였던 건가? 혹은 포스테리어 파시큘라 VT 면을 설명이 될 것 같습니다.
Okay, so because QRS is narrow and all this going on, would it be if the patient does not have a dextrocardiac pattern of ECG, then you say this is a ventricular tachycardia, possibly originating from conduction system, but you have basically axis changes in the right bundle pattern. So would it be left ventricular tachycardia originating from conduction system, which anterior posterior fascicle? Which one?
VA dissociation 전혀 없었고,
Right.
웨이브하고 그 F 웨이브인지 P 웨이브인지가 이렇게 매치가 되는 걸 봐서는 BT에 대해서도 조금 상당히 의심스러운 부분들이.
Well, the other potential option that we did not discuss, patient could have a double tachycardia. Atrial flutter with the ventricular tachycardia going. That we have not discussed, right?
매우 레어하지만
Yeah, very rare, but is it open option that we need to discuss as well?
20년도로 좀 돌아가서 보면은 저 프리코디알의 T 인버전은 왜 생긴 것 같지? 김대원 선생님. T 인버전.
쭉다 보이려면 5, 6까지.
동 얘기한 RB 스트레인.
RB 스트레인 패턴이에요. 엑시스도 노멀 엑시스고.
So this EKG was obtained immediately after tachycardia termination, or this how what's the interval you obtained this ECG between two? Right after?
아데노신 투약했을 때.
Adenosine catheter. Okay.
우와. 야, 오늘 이 케이도 완전히 반전의 연상이.
Okay. So what happened with adenosine?
진짜.
Patient went the tachycardia, and then underlying is atrial flutter, right?
네. 프라로 원투원입니다.
Show the termination first, my friend. Go to a little bit to the left of your screen. There we go.
조금 줄이세요. 밑에 있는 거 좀 내려가지고.
Okay. So
화면으로 보여주세요.
yeah. So where do you think that's this now tachycardia coming from?
좀
Atrial flutter, but we see clearly better what's how they terminate with adenosine. There is after adenosine, there's a certain acceleration.
네.
You see that? Why accelerating? So what happened with the
이게 패치
adenosine?
뭐 미친 거 아니야? 근데 다시 연결시켜서 지금 근데 여기 보면은 V5, 6 줄 써 있는데 보면은 V5, 6가 또 포지티브 RFP라고 했는데 여기도 아까 봤다는 QR사 바뀌었어.
엑셀레이션 되는 시간은
바뀐 게 아까 우리가 본 모양인데 V10가 SE
No, the QRS changed during your adenosine, not before. You can see that the tachycardia ongoing, and then your RR interval suddenly changed there, which is changing your QRS, right? So you need to explain this. Why the axis changes suddenly with adenosine?
이거는 진짜 더블 타키카디아가 온 거 아닌가 싶은데요, 선생님?
That's what I think.
RR 인터벌이 지금 액셀러레이션 되면서 엑시스가 확 바뀌어버렸거든요.
Right.
그리고
And
아직
then,
AB 블럭을 만드니까 플러턴이 있고 그래서 저건 아까 우리가 봤던 그 EKG 엑시스, 타키카디아 엑시스가 똑같아 보이는데 더블 타키카디아가 저기 아다니션 주면서 넌 서스테인에게 나오다가
so if you go up to the screen here, the first tachycardia that you see in the left side screen is consistent with the sinus rhythm, right? This is first bit here. This is not doesn't look like a sinus rhythm. EQRS complex with the alternance, right? Keep going down. So V1 does not have much right bundle. First is to whatever that not a complex tachycardia, right? Do you agree or not? So this could be flutter 2 to 1
네.
with the alteration, a QRS complex alternance. Okay, then what happened? Adenosine, when adenosine was given, how long before this you gave? So once adenosine, what happened? Then you see that clinical tachycardia pattern that we use a 12 ECG, right? With faster rate. Agree? So then what's the mechanism here?
RR이 살짝 길어진 거죠.
RR이 짧아졌죠? 길어졌어?
네.
First bit is a little bit longer, but the subsequent bits
길어지면 시작돼요.
yeah. But look carefully. What happened with the RR interval? They're getting shorter before termination. You agree?
그러니까 여기서 이미 지금 RR이 잠깐 길어질 때 AB 블록이 왔고 그 다음에 non-sustained BT가 오고
Right. Then terminate sinus.
만 나온 것 같은데요.
And then sinus beat, right? 2-3 beat. Isn't that a sinus rhythm? AB association?
계속 가고
Slide sinus or slow flutter?
slow flutter.
Slow flutter with the BA dissociation.
네.
Agree? And
Agree.
then what's the mechanism of that faster tachycardia then? Guys, we gotta discuss all this. You can't just go over this thing without it. So why the tachycardia accelerate before block? How do you explain that?
BT.
VT, what kind of mechanism VT does that? I'm trying to get into that. Usually automatic VT does that. Acceleration, progress acceleration, and age block, and then you got a 2-to-1 block going on, probably the VT, slower, sudden drop the rate. So you need to measure the this RR interval carefully. Okay. So then what happened? So then we agree. So flutter going on, varying degree of block. And then QRS got narrower again. How this a continued rhythm strip or it just interrupted in the middle here? Did somebody cut it? I think you have the way down.
그죠?
예, 이거는 계속입니다.
계속이야? Okay. So then basically you got a long AV block. Somehow AV block controls the patient's VT. Okay, let's go take a look at this VT, how they speed up. Okay, keep going. Now the other side, after adenosine, what happened? Okay, keep going. So QRS remain like a VT morphology we saw. Keep going. And then what happened? Acceleration again. So then what we can conclude from this, let's summarize it. Patient had the adenosine sensitive tachycardia or no? I'm asking question, what's the mechanism of ventricular tachycardia based on your adenosine response? Is it focal tachycardia or the reentrant tachycardia?
automatic tachycardia겠죠.
Yes, focal tachycardia. Where is it coming from?
classical.
Hmm? This is not a classical pattern fascicular VT, correct? Okay. Other differential possibilities what? Such given error complex is a right bundle branch block pattern, right? You agree? This VT changing king morphology a little bit. The clinical one, so we will say the right bundle pattern, right? So it's a left ventricular tachycardia because the V1 is still positive. And then how about axis, this tachycardia? Is it not unusual? It doesn't look like a fascicular VT.
Yes.
If not a fascicular VT, where it come from?
posterior.
Posterior? What? Papillary muscle? Possible?
스트로비티 가능성이 더 높아 보이는데요.
What kind of tachycardia you said? I'm talking about possibly conduction system. I think involve Purkinje network. That's for sure. Question is what focal tachycardia this is.
아니 뭐 vascular BT, post vascular BT랑 꼭 reentrant BT일 필요는 없죠.
Well, it's is it possible? But then your axis is not quite clear because your lead 2 and the 3 not consistent of the fascicular VT pattern because you're too much notching in the lead 3 especially. So could it be what do you think? What do you think? Just conduction system, any Purkinje fiber does that? Differential diagnosis we have to make is unusual form of tachycardia is what? Certain tachycardia come from false tendon, right? Yeah. So we need to think 3 different sources. One would be Purkinje network possibility is one. But if you Purkinje network, this is not a fascicular. It's gotta become a little bit higher. Second would be papillary muscle, Purkinje VT. You know, Komachi wrote a paper with Dr. Altogether, fascicular, post-papillary muscle like a fascicular VT. Remember that paper? So take a look at the after conference.
Komatsu.
Komatsu, yes. Nogami co-investigator. He wrote about 12 or 17 case of papillary muscle like fascicular VT. And other one would be false tendon VT. Because the conduction is very fast and narrow, adenosine sensitivity and all this possibility, rate-dependent phenomenon, it's got to be carcinoid-mediated. So I think focal tachycardia, but those would be a potential source of tachycardia. Okay, now you change how you're going to study this patient, huh? Okay, what else? Anything else we need to discuss? Okay, let's see what the patient did.
와, 이거 그렇구나. 노멀.
옛날에 혈관을 나타나신 쿠션 디지즈 PDA 옛날에
PDA.
메브스랑 본탄 수술했던 환자.
빵 챙기고 있었어.
So patient has a common AV valve. I see. Okay. Glenn shunt. Wow.
엑서사이즈 테스트 할 때 운동할 때는 없었고 레스팅 할 때 조금 PVC가
PVC.
에코가 소화 프로토콜밖에 없어서 좀 저희한테 익숙하지가 않아서 CT로 보여드리면은 심장 몰폴로진 이렇게 되어 있어요. 이상입니다.
So, so this patient, you guys studied or not yet?
Not yet.
Not yet.
네.
So how are you going to study this patient? Amja 선생님 is there? Amja 선생님, is it there or no? Not there? Okay. So you got a plan to study this patient, I assume. So you have to ablate the two together? You're going to ablate all together, I assume. Okay. All right. We're going to read the CCG. Do you guys see atrial activity in this ECG? Any P wave anywhere? That's the first thing we need to see, right? What's the P wave activities are. After that, you're going to see QRS analysis. And after that, you're going to look at the pattern of QRS complex. And then you're going to see what the correlation between atrial ventricular activities and then the pattern of activation.
Why the QRS rhythm이긴 한데
Right bundle branch block pattern.
굉장히 QRS 몰폴로지는 그래도 어느 정도 오거나이즈 돼 있는데
There's a group beating pattern, right? There's a group beating, especially you get the precordial lead. 1, 2, 3, 1, 2, 3. Pattern of pretty similar, but not exactly the same. And any P wave?
리드 1에
Okay. You see P wave? Yes.
PRS 사이사이나 노치 같은 것들이
Right.
저런 데다 P 노치들이 다 보이는 것 같아서 HR 리듬이 더 PRS보다 빠른
Yes. So you have more HR activity than QRS. Okay. You're doing good. So that means what?
뭐 HR
Flutter. Yes. Because you can see that flutter wave deforming the notch of a QRS complex time to time. Look at the AVR, for example. You can see inside the QRS there's a notching. Then I'll come back up a little bit a segment. Yeah, that one. And then inside the QRS, let's assume there's another one. There's another one there. Okay, there's another one there. Next one there, there. So this pattern would do favor for some sort of a flutter fast atrial activity, right? Now, QRS complex is a right bundle morphology, right? Axis is negative inferior, possibly in the lateral lead, superior. So where this coming from, this QRS rhythm here? So typically when you read ECG, it would be anterofascicular block pattern, would you read, right? So what's the potential differential diagnosis we can make?
처음에 딱 보고는 HL 피브릴레이션에 또 QRS 위드스도 좀 조금씩 바뀌는 것 같아서
Okay.
트릭스에
But-
굉장히 안 했었는데 그거
Like if,
한
right?
걸 보니까 또 그게
Right.
아니고
So if atrial fibrillation, then your RR intervals are too many group beating going on pattern, right? That's how do they explain. So it has to be somewhat organized rhythm than atrial fibrillation, atrial activity if you're driving the ventricle. So that may be favor for the some type of flutter or ectopic atrial tachycardia, those are nature, right? So if the P wave, and I mean the atrial activity is negative or positive in an inferior lead. If you look at the lead 3, most of those notchings are looks like a negative, right? Also AVF, maybe even lead 2, perhaps. So that doesn't look like a positive. And then AVL may be positive. So well, how do you read this ECG here? There's a possibility that could be atrial flutter with the left anterofascicular block pattern, right bundle. You could read the aberrancy, or you could be a different level of block. For example, Mobius 1 block kind of pattern is a possibility could explain this group beating. And any other differential diagnosis we need to make here? This could be VT, like a previous case.
이티도 감별해야 될 것 같습니다.
Right, I think you have to make a differential diagnosis. This is a VT or not? This EKG probably to meet the VT criteria. Because you got access way up to the AVL, is positive, right? And then V6 QRS is very difficult to read, but it looks like a more S than R, V6. As far as I can see. And V5 is almost isolated QR there. What is against the VT here? Even though it's a wide variation there, but then V3, you still have a little bit of a hard to know Q wave, or it is just the summation of a P flutter to the depth. So who favor for VT?
이게 어려운데. 줄여볼래.
Hmm? Anybody favor for VT? Nobody?
저는 일단 BT에다 표 던지겠어.
VT?
BT
Anyone else?
두 사람. 세 사람. 셋. 되게 어려운 머리가. SBT.
SVT with the what? Flutter?
해석이 못해요?
정답을 알고 있어요.
아, 정답을 아니까. 3대 3입니다.
Okay. Any okay.
같은 이제 3시간 뒤
Mm-hmm. Now make more sense now. For HR flutter, we knew that the patient is a flutter, right? But why the EKG pattern changing? So that Q wave we saw in precordial V1, V2, especially V3, that's Dr. Peter reading is that's a subtle MI. It's not normal to have a right bundle Q wave all the way down to V3.
픽스드 번들 브랜치 블럭이 있는 상태에서 MR가 안 됐다 얘기인가요?
Yes, that's correct. So it is sometimes difficult to make a differential diagnosis VT in the setting of acute myocardial infarction, and that is what he talking about. But initial group reading, and I think it was a 2-level block, 3-to-1, 2-level block going on, I think. So there's a AV nodal block, and then also lower conductance test. Otherwise, you do not have a Winkelbach type. You have a Mobius 2 block, or you have just 1-to-1.
현재 이거 다시 한번 가볼래요? 그럼 여기서 어느 게 지금 픽스드
So
번들?
if you look at the V3, look at the V3. You got first 3 beat, yeah, and then longer period, next 3 beat, and then you got only show the last, yeah, that's so almost same interval. Can you measure that? So measure between number 3, number 4 bit, and number 6 and number 7 bit. Okay, there's a grouping pattern going on. That's why he thinking that the 3-2 block going on, but it could be a certainly double block, AV node and further down in the conduction. So either explanation could be explained this.
그다음 신전도 확실한데 이 신전도는 시간도
설명을.
Yeah, he thinks that the RR interval is regular here, but when I measured it, when we studied this, I thought that was RR was slightly changing, getting shorter, first to second to the third. But he thought that was very regular, but I did not think that was.
픽스드 브랜치 블럭이 있는 상태에서 반대편 패스크랩 에버리스 생기니까 밸런스드 블럭이 생기면서 QRS 약간 좁아졌다.
Right. For that reason, I think there is a cycle length variation. Unless you have a cycle length variation, you have no reason to change a degree of further down block causing Winkelbach. Okay.
페이지 컨퍼런스 너무 시간을 많이
Okay, let's go to case then.
이해해봐야 될 것 같습니다. 오늘 잘 재미있는 페이지 많이 잘 들었습니다. 버리기 스타트. 오늘 기준으로 모르겠어요.